Okay, and you're seeing my Kaplan screen, right?
Yes, I can see it.
Okay. So I'm not sure if you realize that for the test that you're taking under health promotion, that you see a lot of questions on brachytherapy. Did you see that?
Yes.
So this is what I want you to start with. I want you to do safe and effective care. So this is what you're going to start. You're going to work on this for 3 weeks. Starting today, this is what we want to focus on for 3 weeks. All right?
So don't start with health promotion in it.
No, we want to
Okay.
start with, and as we talk about this, look at this. This is another thing I want to show you. You see this? This is the same
Yeah.
thing I'm showing in Kaplan. Safe and effective care environment is one of the largest section on the NCLEX. Management of care has 15 to 21%. No other section has such higher than management of care.
Okay.
See that? It has the highest. And so on Kaplan, safe and effective care environment cover management of care and safety and infection control. So with that said,
Yep.
yes, we want to start with this section because it is the largest on the test. All right.
Okay.
Okay. Where did I have the Kaplan thing? Okay, here we go. So I'm not sure if you got a chance to review this. Did you?
Not completely. No.
Okay, so this is going to be very, very important, as I mentioned, and I know I'm sounding like a broken record, but if you don't do this, it's going to defeat the entire purpose. All
So
right.
for this one, I'll talk about bronchotherapy. So I could let me show you what I wrote.
Okay, so you wrote down some
I
stuff.
only did stuff for broncho brachytherapy.
Okay, brachytherapy. Okay, so tell me what it is that you know about
Yeah.
it.
So this is what I wrote. It said internal radiation therapy places
Mm-hmm.
a radioactive source directly into or near a tumor.
Mm-hmm. Good.
That's the patho. The nursing roles, I have three sections. There's a pre-op, then there's during treatment, and then post-op.
Mm-hmm.
So for pre-op, you would educate about the procedure. You get informed consent. You prep patient physically, i.e., bowel prep, NPO. Then you have emotional support, address anxiety if there is. And then during treatment, I have radiation precautions, distance away. I mean, safe distance away from patient,
How many
time away
feet?
from, I think at least 6 feet. I don't have
Six
that
feet.
written down,
Yes. Good.
but time away from patient. You don't want to spend prolonged time in the patient room.
How much
Use
time?
that. I did not see that.
Less,
Should look
okay,
at
less than 30 minutes.
less than 30 minutes. Something like that. 30. Okay, and then use lead aprons and such protective measurements. Um,
Mhm.
all right, and the patient must maintain prescribed position if the implant is temporary. Um,
Mhm.
I put an asterisk next to that one. Sorry.
No, go ahead, continue.
Yeah, did you hear me? I don't know
No,
if I said it.
you said you put an asterisk beside this one. What okay, what did you put a asterisk
I
beside?
said patient maintain prescribed position if the implant is temporary,
Yes. Yes. So that
and
it
then
doesn't fall out. And if it falls out, what do you do?
if it falls out, that I do not know. I didn't see that.
Okay, you use a forceps, you're gonna use a forceps to pick it up, but you have to call the radiation department for them to come with their hazard team and so forth to take, but you wouldn't leave it on the ground. So whichever way it goes, there's a long forceps that you use, right? What about radioactive? Any precaution with anyone when
Yes,
they?
I was getting there.
Okay, go ahead.
So, and then you also monitor for discomfort or pain during the procedure, because this is during the procedure,
Oh, this is during
during
the procedure.
treatment.
Okay, all right, go ahead.
All
Yes.
right, so now I told you there's three sections. Now this is post procedure. So
Mhm.
you assess for side effects, swelling, bleeding, fatigue. Provide discharge info. Um, if provide discharge info if permanent, distance away from children. Yeah, if it's a permanent brachytherapy, of the permanent implant,
Mhm.
then you would have to inform the patient about safe distances with children and pregnant women.
Okay. Alrighty. Good, good, good. Alrighty. So you see what you just tell me? You're going to record that for even yourself. Cause I went back and I looked um on the videos. I noticed you didn't watch the videos, but it didn't line up with what we're covering, management of care. So that was fine. But make sure that you record it and you listen to them. All right. So you have that down pat. You have what to do before, what to do intro, what to do post. You know how much time they should spend. You know what distance. That's good. What's the name of the monitor that the nurse should wear when working with a patient who have brachytherapy?
The name of the monitor they should wear,
Yes,
that
it's
one
called
second.
it's called a DOSI monitor. It's a device that measures the amount of radiation they're exposed to.
Okay.
It's called a DOSI monitor. And a couple of things too is that use tongs. I said that already, and a lead container if the thing is dislodged. In addition to that, while they should not be with children, young children, also sexual intercourse should be avoided, right? In about 1 to 2 weeks after being discharged, they should limit sexual or avoid sexual intercourse. Okay, so
Okay.
that's a good start. Did you go any further? And I noticed that there was a couple, just it was like 6 or 7 questions on that.
Yeah,
Uh,
I didn't get any further.
yes. Okay. So remember, this is like going to be your full-time job. So a couple of things that even when I was going over it that you can pick up if you remediate like this. The goal here is for safety precaution because of the radiation. And another thing they want to monitor for is for managing urinary symptoms. So that's one. So when you're going over it, you're going to, just by the answer that is giving you, you're going to learn certain things. In these one, you will be discharged at home the same day of the procedure indicated. You will need to isolate, you will need isolation period at home away from others. And it says not indicated, but remember, only children. It's important to avoid very close contact with children. Indicated, that's true, but not with others like an adult. More afternoon fluid intake, including caffeine, can reduce nocturia. Not indicated. Here's the thing. Um, you want to prevent dehydration, so they want to drink a lot of water, right? It does not reduce nocturia, especially if you have caffeine. All right.
Yes.
So that's a good one. Ice pack, you get that because it may have tenderness. And here's a learning thing. So you got this one wrong because you said not indicated. It says tamucil, tamsulicin may be prescribed to help with very difficult voiding. Indicated. So now you know that this medication, so this is how you can reverse it to even write your notes. Now you know that this medication can be helpful with individuals who are receiving brachytherapy and are having difficulty voiding. You will need to strain your urine at home for a few days. Indicated why? Just to make sure that there's no leftover from the seed implant that's been there. So these are things that you can use to say, okay, that means I do need to strain. Okay, and that means this is not going to happen. So these are ways that you can use this question to answer that. All right. And there, look at this, check for the PSA level. And this is the same thing. And this is how because this one said client reports the adult child and grandchildren have been staying with a sibling. And that's correct. Because remember, prior here, it's important to avoid grandchildren or children. So when you come over here now, they're testing your knowledge now to see if you know that you should stay away from children. So they asked it to you because remember, this is a computer adaptive testing. So they ask this to you, but they ask it to you in a different way. Adult children and grandchildren, which is the grandchildren, which is a highlight to see if you actually get that.
Because they say adult child. Yeah.
Adult child and grandchildren. So there's a grandchildren that peaks the part here. All right. Okay. So I want you to really get on this because when I'm going, remember, I'm going to need your notes. I need a screenshot of your notes. I need you to send them over to me when you record them. This will, one, keep you accountable as a form of accountable thing and make sure that you are on track. All right. Okay. So I'm going to touch some things on, so starting from today, remember, you're going to go to safe and effective care per the plan that you're using, safe and effective care environment. That's the quiz you're going to go on. That's the section you're going to go on. When you go on Kaplan 2, you will see safety and infection control videos, so you can watch those because these test questions come in one. So this is what we're working with for 3 weeks. Okay? Okay, so I'm going to touch some legal issues, and I made these PowerPoint very detailed for a couple of reasons. So if while I'm speaking, you'll be able to also read the words on the screen. So they're very detailed PowerPoints. Okay. So this is about legal rights and responsibility in nursing practice. All right. So as it relates to understanding the legal framework, when it comes on to nursing, we are one of the most heavily regulated profession when it comes on to the healthcare. I mean, doctors too, and anybody, but nursing, because we have such a large body of nurses. And the nursing profession, actually, there's an interaction between ethical practice, legal requirement, and also patient advocacy. Right? Because some things may be right, but it's not ethical, or it's ethical and it's not right, and what the patient wants. So there's sometimes that gray area. And every clinical decision you make have a potential legal implication to it. So if you understand this framework, it not only protect you, but also protect your patient, yourself, and your colleague. There was this nurse who was transferred from one unit, and it's a real life case. She won the case. I heard it this week or last week. She was working in the ICU, and she gave I don't know what she did. The patient was intubated, and she did a procedure, and they said that there was no order for it, and she shouldn't have done it, and so forth. So she was at risk for losing her license. She took it to court. She actually won the case because she was saying that there was some racist or discrimination against her or stuff like that. So she actually won the case. But when it comes on to legality, nursing, and I'm telling you this for NCLEX, yes, but I'm also telling you this when you pass the NCLEX and you start practicing. CPR, I see nurses calling for deposition for CPR. If not done properly or done properly. So we're talking about key legal concept that you must know is your professional liability and malpractice, patient rights and autonomy, informed consent and refusal, HIPAA, mandatory reporting, scope of practice and boundaries, documentation. And remember, your documentation is one of your legal documents, legal thing that's going to protect you more than anything else, because you should know this by not that if it wasn't documented, it wasn't done. All right. So patient rights, one of the cornerstones for legal practice. So patient must receive adequate information about their condition, their proposed treatment, the risk, the benefits and the alternative before agreeing to care. It's not just, okay, here, we're going to give you this medication. So you want to practice from now to say, Mr. Jones, here's your blood pressure medication. It will help lower your blood pressure. And for surgery purposes, when we're talking about informed consent, the surgeon who's going to do the surgery must come and tell the patient that you have this condition. Here's a reason for the surgery. Here are the risks of the surgery. Here are the benefits of the surgery. Here are the alternative before agreeing. And that's why it's not that your informed consent doesn't mean that you're giving the surgeon the consent to do the surgery for you just like that. It means that the patient was informed, and because they were informed, they're now consenting to the surgery. That's what informed consent means. Rights or right to refuse treatment. So if a patient is competent, if they're a competent adult, and they have absolute the right to refuse treatment, and even if refusal will cause their harm or death, they can refuse it. So this right is protected by law and it must be respected, although not everything as you as a nurse are going to agree with. And I have a couple of stories to tell with this. For example, I had a patient, it was a teenager. He was 19 and he was in the nursing home. And I just cannot see a 19-year-old diagnosed with HIV passing away when there is so much medication, there is so much treatment. So he had refused to take the treatment. And as a nurse, I know that if he takes the treatment, that he would survive, because people are living so long with HIV now. There was no reason for him to die with HIV/AIDS. So I actually spoke to him and his mother about starting the treatment. He was actually on hospice. Do you know what hospice is?
Yes, there. It's like right before they're about to die.
Yeah,
Yeah.
they have 6 months or less to die. All right. And I spoke to him and his mother about starting treatment. The mother was excited. He had said yes. And but we'd have to call the hospice team, because there's certain diagnoses. If you are on hospice, you can't get treatment for it, because remember, you're going to die in 6 months or less. So they're not going to treat you for the problem. So now it causes that they need to get the doctor, get the order. So there's a little delay. Anyway, about 3 days after the patient died, oh my gosh, I was so devastated. Now, what's the difference between him saying that he doesn't want the treatment versus me, telling the pros and the cons and what the data said and what the research said? That's different. And even the same thing with vaccines. You have some parent will come in and say, I don't want my child to get vaccine because it causes ADHD or it causes some diseases or whatever. You can give them the facts. According to research study, there's no study that showed that it causes autism or it causes ADHD. And if you tell the patient that and they still refuses, you can't force them. They have the right, especially if they're alert, oriented. And even for patient you may have a patient who has schizophrenia. And I want
Yeah.
you to remember this. So having schizophrenia, doesn't mean that you're always in a bipolar or a manic state. You have people who have disease, and there's sometimes the disease is activated. Like, for example, asthma. Asthma is a chronic disease, but somebody don't walk around with asthma all the time. It will get exacerbated at some point, right? But sometimes they're free of wheezing and it's fine for a couple of months or weeks. And then maybe during a particular time, they may have an attack. It's the same thing for someone who's diagnosed with bipolar, for example. Is not because you're diagnosed with bipolar that means they're having a manic phase right now, or they're going through a depressive phase right now. No. So they too have rights. They have right to decline. Even though they may have a mental health diagnosis, they have the right to refuse. Another story about the right to refuse. I was working in the emergency room in Jackson, and this patient came in. She was a Jehovah's Witness patient. and she was anemic, and she needed a blood transfusion, and she refused the blood because she was a Jehovah's Witness. I mean, there are other things they can do. They can give her maybe plasma, they can give her fluids, but it won't be as effective as giving her blood. I mean, it's her right, but inside of me, I know that she can survive and she can live if she get the blood. It wasn't my patient, but one of the things that the nurse who had her come and tell me, her husband left, and she asked if she can get the blood before her husband came back because she didn't want him to know that she took the blood. I'm just saying that a client refusing something, they have the right to refuse based on religious purposes or their whatever they think. Yes, you can educate, but if you educate, it's not force. So you have to look at the word. It's not educate, it's not force, but educating them, and they still refuse, then we have to respect that. HIPAA protects patient health information, and nurses must maintain confidentiality. Share information only on a need-to-know basis and obtain authorization before disclosing protective health information. And I remember this because there's a lot of, I've seen many questions and things like this, and nursing students get confused. If the physician is not a part of the patient care team, the physician does not get information on the patient. If the priest come in and the priest is not a part of the patient care team, they should not get information on that patient. So it doesn't matter who it is, they must, even though they work in the hospital, even though it's a priest that have the chaplain in the hospital, if they're not a part of the care team, they cannot get information on the patient. There was a famous, I don't know if it was Beyonce, I don't remember who it was, but there was a famous person who went into the hospital and some information was leaked out to the press. And what they did, the IT department of the hospital ran everyone who logged into the patient record was not directly related to their care. So if you're not directly related to your care, you should not look into the patient file. Just like if you're working in the hospital and you see your neighbor come in and you're not your neighbor's, and one, you should not be your neighbor's nurse. If you see a family, a neighbor, a friend come in, you should ask, say, I know this person, and you should ask to be reassigned or have that person go to another nurse. And even though it's your friend, you should not access information. Your friend said, even say you're going to look on your friend look for your friend in the break time, and he's like, Kareem, man, what I didn't get my report. I didn't get my labs yet. What did my labs say? Do not log in to your patient's, to your friend's record with your name, because then at the end of the day, they can say that's an invasion of privacy. That's not your patient, and you should not get access to his information, and then you're violating the HIPAA.
Even if it's the patient that tell you to do it.
Even if it's a patient that tells you to do it.
Oh, because that sounds like it's them giving you consent in a sense.
Well, but it's not your patient.
Okay.
No, it's not your patient. All right, not your patient. Is unless you're the charge nurse and you're covering for a nurse, and the nurse go for lunch and you're covering, so no, you can access, because that's a legal thing, a legal issue that can occur.
All right, so let me ask you, so what case is this okay? So let's say this is your patient and I'm the nurse, right? Can I come to you and ask you, let's say you came to me, let's say you didn't know anything, you're just a nurse, and you came to me, you asked me, can you check the labs for so and so, right? Am I allowed to do that still? Or
so NCLEX is the perfect nursing world. In the hospital,
in my scope.
Yes, but in the hospital, they do that all the time. In NCLEX, you don't.
Hold on, you're breaking up.
I said,
can't hear you. Hello?
I said in the hospital. Can you hear me?
Yeah, I can hear you now.
In the hospital, they do that all the time. But in NCLEX is a perfect nursing world. You do not access any patient information that you are not directly related to their care.
Ever.
Ever. in NCLEX. All right.
Okay, yeah, because I'm like, it sounds like, because I'm like, you're telling me about delegation, and it's like, can they delegate? Can someone delegate that
Okay.
to
So
another nurse? Can you do? Can I delegate a task to? Well, because it's my patient, but I guess you cannot in a sense, because you only could delegate to the
if your
CNA that's
supervisor,
with
yeah,
the
no,
patient.
but if your supervisor come to you and said, Kareem, the nurse for 405 went out, she's not feeling well, or she got a call to HR, she got to go, look, cover patient room 5 and 6. That is different
Okay.
because your supervisor delegate that to you to look after patient 4, 5, or 6. But there's a
Okay.
couple of things that when it comes on to nursing, especially protect your license as much as possible, especially you being a young one coming in, you're the easiest to go under the bus. But you should not just, your friend shouldn't just tell you, okay, can you look up this record for me or can you look that up for me? No, you want to set those boundaries. And what
Okay.
NCLEX is saying, that's how it is supposed to go. It doesn't work like that in the hospital because they don't follow the rule, but that's how it is supposed to go. All
Okay.
right. A right to self-determination. They add this section a couple of years ago. Patients have the right to make decisions about their own health care, including the right to create an advance directive, designate a healthcare proxy, and have their wishes respected, even when incapacitated. Um, so if you watch the videos, make sure you look at advance directive, what they are, healthcare proxies. And so advanced directives are tools like will, do
Yeah.
not resuscitate order, healthcare proxies. All right. So that's what encompass part of self-determination. They have the right to make these decisions about themselves. So advanced directive is like making decision in advance. If I should become incapacitated, I want this, I don't want that, I want this, and I don't want that. Listen, this part here is one of the largest part of the NCLEX. And what happened is that they will give you a person come with a heart disease, triple bypass, and is going for surgery. In something about informed consent. A person come with kidneys, so they're going to put kidneys inside there, any part, any one of the body system. But then the essence of a question they're asking you is going to be about management of care. So you need to get this part down pat. All right. So if you need to watch the videos over again, please do so. Treatment refusal. So one of the most challenging legal issues nurses face is when a patient refuses recommended treatment. And believe it or not, it can be so painful because sometimes you know more than the patient as it relates to the treatment, right? And the patient refused, but still having the same problem. So the right to refuse treatment is grounded in an ethical principle called autonomy. Please remember this, and I think it's listed in one of my videos when I talk about autonomy, beneficent, maleficent, justice. You need to know all of those, right? So what or the right to refuse treatment comes underneath the ethical principle. It comes underneath the ethical principle of autonomy, and it's also a legal aspect that they're protected with. However, this isn't an absolute because there are some patients who are considered that they're incompetent. They're not necessarily competent. All right. And they have to be competent to make those decisions. So let's look at the legal requirement for valid refusal. Competency. Patient must be mentally capable of understanding the decision and its consequences. If not, the court can hand down an order that, hey, listen, you need to be on the treatment, you need to get this, and so forth, if they're not competent. Information. Patient must be fully informed about the treatment, the risk, the refuse, and alternative. Voluntariness. Decision must be made freely without any kind of coercion and undue influence. There's two stories that I'm going to tell you that lines up so much with this. There's a Tuskegee group, you know, those guys who they said they run hepatitis studies on. Have you heard about
No.
Tuskegee? Yeah, these were some black guys. it's called the Tuskegee group or guys that they actually did research on, and it was considered unethical. One, they didn't volunteer. They weren't told. They were competent, yes, but they weren't given the information to be volunteer part of it. And then there's this other African American lady who they harvest her part and get to create some, because of what they did, they were able to make some kind of vaccine. And I think it was about 5 years ago, her family line actually sued the state and was able to get compensation for it. So this information must be voluntary. Decision must be made freely without any kind of coercion. The patient must understand. That's why even today, if someone should ask me about a patient that I had 15, 20 years ago, if I look at my documentation and my documentation say patient verbalized understanding of information given. That's whenever I teach patients, and up to date as a nurse practitioner when I practice, and I'm educating patient on exercise, lifestyle, and all of that, I always put patient verbalized understanding of information given. All right, you want to make sure the patient understand, and it's not good enough to say, yes, the patient had told me. Remember, you need to document, because if it wasn't documented, it's not done.
Yes.
So what's your responsibility as a nurse? You want to assess if the patient is competent. Evaluate whether the patient understands their condition and the implication of refusing. You want to ensure informed decision. Verify that the patient has received the complete information from the provider about their risk and alternative. Document the patient, the refusal of the patient. And there's some test questions sometimes that will say, what would you do? Would you call the doctor first? Would you teach a patient about the surgery? Would you document? One of the first things you want to find out, if the patient refused or is having an issue, you want to find out first, like, what are their concerns, right? And here is where the critical thinking comes in. Because if the question told you, or the question already states, Mr. Brown, who is scheduled for ORIF, said that he doesn't want to take the surgery because he doesn't know which leg. The question already told his concern. So it wouldn't be, the answer choice wouldn't be to ask him what his concern again. It may be to call the physician or call the surgeon. You understand that? But if in the question it just say patient refused to go to surgery, what would the nurse do next? Is ask, could you tell me your concerns? Because when you go, you can't just go call the doctor. The doctor is going to ask you why. Why did he refuse, or what did he say the problem is? So you want at least that information to tell the provider. All right.
Okay.
And then when you're documenting, then you can say patient refused, patient voice, so forth and so on. Surgeon was notified and so forth. So you want to make sure that you immediately notify the provider and continue with supportive care. Remain non-judgmental and continue to provide care with the patient's wishes, and obtain signature. Have the patient sign a refusal of treatment form per the facility protocol. Now, here's where the critical part comes in. If you suspect that the patient lack the capacity, that they don't have the cognitive ability to make the decision, if they're confused, if they're underneath the influence of alcohol or drugs, if they're cognitively impaired, notify the provider immediately. All right, because they may have to do additional evaluation and may need to take it even a little bit further. All right. So let's look at this case study, treatment refusal. Mr. Johnson, a 68-year-old male with type 2 diabetes, is admitted with a foot infection. The physician recommends amputation to prevent sepsis. Mr. Johnson states, I understand I could die, but I am refusing the surgery. I've lived a full life and I don't want to lose my foot. All right. Now, for a lot of nurses, like I would say, I don't want to die. If I can live with just one foot, I'd prefer to live. A lot of people may think that way. But for Mr. Johnson, so step one, you want to assess competency. Mr. Johnson is alert. He's oriented to person, time, and place in the situation. He can explain his diagnosis. the recommended treatment, potential consequences, and he demonstrate decision-making capacity. Step 2, you want to verify informed consent process. Confirm with the physician that Mr. Johnson received a complete information about his condition, the risk of refusing the amputation, such as sepsis and death, alternative treatment, and expected outcome, ensuring that he had the opportunity to ask questions. And then step 3, document everything. Chart patient verbalize understanding that refusing amputation may result in progression of the infection and potential death. State, I understand the risk, but don't want the surgery. And you see, those are in quotation because there's a time when you're going to need to quote exactly what the patient said. And then you're going to document that the patient is alert and oriented ×4, physician notified, patient signed refusal of treatment form. And then step 4, you always still want to provide support, comfort support, like pain management, emotional support, discuss advanced directive is appropriate, and inform the patient that he can change his mind at any time. And as a nurse, we need to remain non-judgmental, and you want to respect the patient, and it is autonomy. Autonomy is a freedom to make decision or healthcare decision that he wants, even though we may not agree. All right. So let's look at these special population. When refusal get complicated, minor generally and legally can't legally refuse treatment.
Unless they're like unless they have a child or something, right?
Unless they have a child, unless they're in the military.
Or they're emancipated.
Emancipated, right? Yes, that's correct. So
that's the only conditions for under 18?
Yes, for under 18. Yes. Do you know Home Alone? Have you ever watched the movie Home Alone? I don't know.
Yes,
you're pretty young.
I watched Home Alone, but I was very young. I haven't watched it recently. But yeah, with Macaulay Culkin. His cousin.
Yes. So he actually went to court before he was 18 to be emancipated from his parent because he didn't have access to his own money. That's what they say, that he didn't have access to his own money, or he thought his parent was using his money. So he actually went to court to be emancipated from his parent. So emancipation is one of those, being in the military, pregnant, correct. So parent or legal guardian make healthcare decision. Exception include emancipated minor, as I said, mature minor in some states, and specific situations. So here's the thing. You have some minors to get STI or STD, sexually transmitted disease or infection treatment that don't need a parent consent. Pregnancy care, they don't need necessarily a parent consent. Substance abuse treatment, they don't really need a parent consent. All right. So when a minor refuses treatment involving the parent and guardian, and notify the provider, and you want to document the minor concerns if they have one and discuss it with them. But certain treatments.
So for a minor, so let's say there's a minor that comes in and they need some type of immediate treatment. You don't get consent, right?
Okay. And this goes for anybody. If there's a car accident, right? And this is a life and death, yes, they're going to try to call the parent, but if they need to do surgery right away, they're going to presume that the person wants to live until proven otherwise. But yes, they'll try while the nurse and the doctor may be trying to get the patient out and do what they're doing to set up for surgery and all of that. You're going to have some other team member trying to reach out to the police, trying to reach out to family, because a telephone consent can also be given. And if they can't get one, then they will go ahead with surgery because they're going to presume that the person wants the life-saving measures.
Okay.
This goes for adults and children. A lot of gray areas, yes. Yes, and
because I feel like every time I read it, the question is always different, and they always try to trick you some differently.
That's so true. So that's why this part, we need to get this over the next 3 weeks, because there's a lot of gray area, and that's it. You're going to say, but wait, but I saw this say this, and when you reach over here, then you say this.
And it's different, and it's like, you can't go off of it.
So one of the things that I needed to do is just pay attention closely to what the question is asking, one, And two, what are the answer choices that it gives to you? Because that makes a huge difference. Just like what I told you, that the patient who said that they don't want to do the surgery because whatever the case was, what would you do first? And you'll see, ask the patient what is concerned, document, reach out to the doctor. It will be reach out to the doctor. But if it's the same question, patient refuse ORIF surgery, and that's the only thing, what would you do? It would be ask the patient,
That's what the concern.
was it concern? So
Yeah.
it depends on what information the question gives you and what the answer choices are. All right.
Indeed. Okay.
Okay. So psychiatric patient, mental illness alone does not mean that the patient is incompetent. And we did cover that. You want to make sure that you assess that the patient understands the situation. If a psychiatric patient is deemed incompetent to make decision, involuntary treatment may be legal, justified, especially if the client poses a danger to himself or others. And involuntary, in Florida here, we call it Baker Act, right? When they will say, okay, we're going to take you in against your will. And so treatment would be necessary and they can't refuse per se. And even if they refuse, they'll even restrain and administer medication, especially in the mental health ward. All right, but follow facility protocol and mental health law in our states based on our Nurse Practice Act. Patient under the influence, and I know you know this one, that influence, yes, we're talking about alcohol, drugs, but it also means sedating medication, because if you give the patient is going in for surgery, right? And you give the patient a sedative before they go into surgery and then taking the informed, oh, I forgot to give them the informed consent to sign. And then you're going to give them the informed consent to sign afterwards, then it's not considered valid. The surgery have to be canceled. You have to wait until the person get an alert or the medication's out of their system for them to sign it. But that sedative that is given before surgery, if the patient don't get informed consent before that, the informed consent is not valid. All right. Assess mental status carefully. If the patient, you suspect that the patient is impaired, the refusal may not be legally valid. Emergency treatment can then proceed. And you want to reassess the capacity when the patient becomes sober, and then you can obtain consent then. And this is what we're talking about early on, about the emergency situation. Whenever there's like a true medical emergency where delay could result in death or serious harm, the patient is unable to consent, whether they're incompetent or unconscious, treatment can proceed under the implied consent. And that's one of the things. There's an implied consent. Go ahead.
Can a minor can refuse treatment as well without?
No, they cannot. A minor cannot refuse treatment.
Okay.
All right. But under certain circumstances, if they are emancipated, if they are married, if they're in the army, if they're pregnant and so forth, pregnant or give birth, that yes, they can. Because if they're pregnant, they're like, no, I don't want an epidural. And this was a question I saw where the young teenager, she was pregnant and the mother was there while she was in labor. She wanted epidural. The mother said no. And who would you listen to? You have to listen to the patient, which is a child. But she's pregnant, right? So you listen to her.
So I'm saying, so because you're saying, remember you said if they come in, they don't need consent if it's drug abuse or something under that line, right?
That's correct.
So now if you're bringing them the medication and they said they don't want it, do they have to still take that because they're still minors, or do you have to go over to the, like, I don't understand. There's like so much crisscross in there.
Alrighty. So there's a lot of health care clinic that deal with STIs. And if you have a minor who goes there and they have STI
and they say, I don't want the treatment.
I don't want to. It all depends on what it is, because you have some that are reportable. HIV is a reportable disease. So even if they don't want it, they have to report to the state. HIV, syphilis, gonorrhea, those are reportable disease. They may not report it to the parent, but they're going to report it to the state.
Okay.
Because those are reportable diseases. All right. And the hope is that the fact that they're coming to seek that what's wrong with me, they're coming to the clinic because they feel something, hopefully that they will accept treatment. But like with STI and so forth, if they suspect, if the suspect that this patient, this child minor was abused or in abusive situation, only thing the nurse need to do is suspect. Don't have to have full proof, just suspect. It can be reported. All right. So with implied consent, there's different type of consent, right? Whenever a patient goes into the hospital, right, they sign a form that says, okay, I'm here for treatment, and they sign a consent for general. But the more specific or the more risk the procedure that they're coming for is the higher the need for a consent. Here's what implied consent is. Implied consent is that it's not written, it's not spoken, but it's assumed by the patient action or situation. In this case, like you go to draw blood and you say, Mr. Brown, I'm here. My name is Nurse Kareem, and I'm here to draw your blood today. And they extend their arm. They didn't say anything. They didn't write anything. They didn't say anything, but they extend their arm. The patient extended arm is a form of implied consent. Like X-ray, patient lies on the table for an X-ray when asked. It's implied. In an emergency, like in this case, where the patient is unconscious and so forth, is implied unless they have documentation that CPR should not be done. There's also express consent when the patient clearly state permission. Either this can be verbally or this can be written, and this is express consent. All right. Okay. Valuables when it comes on to the legal implication. So, and believe it or not, dentures is one of the most missing valuables or from patient that's missing in the hospital. So healthcare organizations are legally responsible for protecting not only the patient, but also their properties. And nurse plays a crucial role in that. If there's a failure to properly manage or document and care for not a care, but properly put away their valuables, then this can become a legal issue. They can claim theft, and this can even build mistrust between the patient and the facility, all right? So most organizations have a policy on how to handle these belongings, such as jewels, money, cell phones, and other things. So some of the most common valuable encounter is jewelry, cash, credit cards, cell phones, eyeglasses, hearing aids, dentures, other kind of medical device, clothing items, important documents like ID and like insurance card. So what is the legal implication? Healthcare facility can be held liable for lost or stolen patient property underneath a legal principle that's called bailment. And this is when an institution accepts responsibility to safeguard someone's property and to minimize any kind of liability. So what they're going to look at, did the facility follow policy exactly? Did they document all the items thoroughly? Did they encourage the family member to take them home? Did they use the facility safe for items that cannot be left out? Did they obtain patient signature on the inventory form? Was there anyone who witnessed the inventory form too? Because the patient may say, well, I gave you a ring. And this was just on social media the other day. No, I mean, just today, there is this girl who is on something of Housewife, a reality show, and someone broke in and robbed their house. And so she made a claim to the insurance company that her diamond ring was stolen. Well, this is not a healthcare facility, but it's kind of the same thing. So now the insurance company paid out thousands of dollars, but when they looked, she went on an interview, she had on the same diamond ring that she said that was missing. I said all of that to say this. A patient can say, I gave you a diamond ring. I gave you a gold necklace. So you want to make sure that you have someone witness the inventory form. And not only that, the patient's signature is on it. Because if the patient's signature is not on it and there was no witness, then that means it's going to be your word against theirs. And there was no kind of documentation to prove otherwise. So let's look at these steps. Assessment and discussion. On admission, the patient should be asked about valuables in their possession. You want to explain policy regarding valuable items. And you want to strongly recommend that they send home valuables with family members whenever possible, as this will eliminate any kind of risk that they lose it. And you want to document that they were encouraged to do so. Create a detailed inventory of all the items that the patient choose to keep if they did not send home their valuables. Use the facility valuable inventory form. Every facility has a form. Document, describe the quantity, the quality, even the condition, including specific details like a yellow gold band and 3 diamonds. Don't just write just a ring. Have the patient verify and sign the inventory list. Items staying with the patient should be stored in the bedside safe if available. High value items should go to the facility safe with security. Complete required forms and obtain receipt number went to the security, and give the patient a copy of all documentation of their records. Ongoing monitoring, update inventory if the patient received new items during their stay, like someone takes something that's valuable. Document any items sent home with the family before procedure or transfer, and you want to verify the valuable items are secured. Never leave valuables unattended to during transport, especially when the patient is leaving their room. And for discharge process, return all items to the patient using the original inventory list. Have the patient verify the receipt of the items and to sign the document that they actually received it. So here's some situation too, because you have some situation where a patient may be going into surgery and you know you can't have on a necklace, you can't have on any ring, but the patient want to have their ring on, right? So let's look at this. Wedding ring and religious items. Many patients refuse to remove their wedding rings or religious medals. You want to document that the patient decision to keep those items on, because patient has to be grounded when they're going into surgery. So if you're educating them about the pros and the cons and they still don't want to remove it, you have to document that they want to keep it on. But here's what you do. Use tape to secure the ring if hand may be swollen. All right, note in the chart, patient declined to remove wedding band despite risk explained, ring tape to finger per patient request. Respect culture and religious significance while documenting your education about the potential risks, like the finger can swell, which will obstruct circulation. They can lose it during procedure. You want to make sure that you educate that to them, or you tell that to them and write it in your chart. Unconscious or incapacitated patients. If a patient become, incapacitated, right? Patient cannot participate in the inventory process, like they are unconscious or they're incapacitated. You want to document valuable with a witness. Get someone, a preferable RN or a security, and you want to know the patient condition. Patient unresponsive on arrival. Valuable inventory complete with witness or Smith and RN present. Attempt to contact family to pick up if possible. So you want to put those in. What about a patient who is deceased? Follow what the specific facility protocol is. And in the NCLEX, most of the information that they're giving you is not going to be specific to one facility or one county or one state per se. It's going to be able to be applied to anywhere in the United States, because remember, it's the same NCLEX everyone take. So as it relates to deceased, all items become a part of the person's estate. You want to make sure that you document and back all the belongings with the witness present. and release all to authorized family member or legal representative with appropriate documentation. And you will never dispose of any item, even if those that seem as if they have no value or any sentimental importance. And you want to make sure that you obtain signature for all release items. All right. What about theft, suspected theft? If a patient report a missing valuable, immediately notify your supervisor and follow what the protocol says for the facility for theft investigation. Do not accuse anyone or investigate independently. Don't go be investigator when it comes to theft. File an incident report with complete details. And remember, incident report do not go into the patient record, okay? Security will conduct their investigation, review your documents to verify what was recorded at admission. And this situation demonstrates why thorough initial documentation is needed. All right. So you want to do it just in case the because suspected theft is the patient saying, no, I give you this. That could be it. Could be someone stole it for real. And it could also be, I remember, where was I? Who was I with? Okay. I went to a conference and my girlfriend had her tablet. And she's like, I had my tablet in my bag. Someone stole it. And I'm like, what? Someone went in your bag to see? She's like, yes, because it's not there. And we turned around to go to the hotel security, and she's like, oh my, I didn't put it in my bag. I forgot. I'm sorry, I didn't put it in my bag. She forgot that she didn't put the tablet in her bag this morning. So I say all of this to say that sometimes patients don't remember what they don't give you, and your only proof is going to be what you documented. So you want to give detailed description, as I mentioned, exact quantity, 3 rings, don't put several, the condition that it was in, damaged or worn, the patient statement, document if the patient refused to send an item home, get someone to witness your form. And also when you give it to security, they will give also your number. So remember, if it isn't documented legally, it didn't happen. So your documentation is going to be the evidence of proper procedure following to protect not only you, the patient, and also the facility. All right. So I'm going to stop here and let me